So hello friends, today we'll start our next lecture on ECG. This will be the fourth lecture on right bundle branch block. Okay. Now, before understanding what are the different criteria and what are the cause of those criteria in right bundle branch block, you have to study some nomenclature. For example, I am telling you this. One wave is like this. Second wave is like this. Third wave is like this. And fourth wave is like this. So how to name these waves? Okay, so always remember 2 points. The first, if there are two R waves, the R wave which is bigger in size will be denoted by capital letter, first thing. Second, the second R wave will be denoted by a R dash. Okay, so if we see this, which one of them is bigger? This. So this will be represented by capital R, and this will be represented by small r. This is the second R wave, therefore it will be represented by a dash, and this is a S wave. So this will be called as RSR dash pattern. Okay, if we look into this, which R wave is bigger? This is. So this will be represented by capital R, this will be represented by small r, and since this is the second R wave, it will have a dash. So this will be called as RSR dash pattern. Okay. Now if we come to this, both the R wave has same amplitude. So both will be represented by the capital letter. But it is the second R wave, so it will be represented by dash. So this is the S wave, so it will be called as RSR dash pattern. Okay. Now if we come to this, which one is bigger? Both are bigger, so both will be represented by R. This is second R wave, so it will be represented by a dash. This will be called as a RR dash pattern. Please remember, each one of them is included in right bundle branch block. Okay. Each one of them is represented in, if in lead V1 or V2 we get any of this pattern, we have to think of right bundle branch block. So this is the initial thing. What was the mechanism behind this? I am going to tell you. So in the class of left bundle branch block, we have studied the 4 vector. The first vector, that was the septal depolarization. Second vector was the septal depolarization from the base to the apex. Third was the ventricle depolarization, and fourth was the basal depolarization. Now we will see them again, but in a quick way. Okay. Now we know that in septal depolarization occurs from left to the right. Now try to imagine, if this is your septum coming out from the board, and this is your V1 and V2. This is your V1 and V2. So due to septal depolarization, the wave will come towards the V1. So they will record a positive deflection. Record a positive deflection. Okay. Now if we talk of lateral leads like V5, V6, 1 and AVL, I have told you that for them the septal depolarization that comes from left to right, due to which the wave will be away from them, so they will record a negative deflection. I am again re-explaining this point, that V1, V2 is present in 4th intercostal space, and due to septal depolarization, the wave is coming towards them, so they will record a positive deflection, and this positive deflection we can denote like this. Okay. Now if we talk of lateral leads, they will, because of septal depolarization, they will record a negative deflection. So negative deflection will be like this. That's why I have told you that in left bundle, normally in lead V5, V6, 1 and AVL, you get a Q wave. And in left bundle branch block, when septal depolarization direction changes from right to left, this Q wave is lost, and thus loss of Q wave is one of the criteria for diagnosis of left bundle branch block. So this is because of the septal depolarization. Now coming to this. Now septal depolarization and ventricle depolarization will have a net vector in this direction. Okay. Now So now if we talk of V1 and V2, so V1, V2 will record a negative deflection because V1, V2 are here. So for them, this is going away from them. So they will record a negative deflection. They will record a negative deflection. And V5, V6, for them it is coming like this towards them. So they will record a positive deflection. I am again explaining this, that V1, this septal depolation and ventricle depolation, the net direction is this, like this, that is inferior laterally. So V1, V2 will have a negative deflection because wave of depolation is going away from them. So they will record a negative deflection. It will be like this. And V5, V6 will record a positive deflection because the wave of depolation is coming towards them. Now, the most important thing, finally the depolation is of the bases. This is the bases, right ventricle and left ventricle. Now we have to understand very important thing, that if we talk of lead V1 and V2, they are normally present in fourth intercostal space. Okay, so this depolation of the bases of the right ventricle or the left ventricle is beyond the scope of these leads to capture them. So these leads are not able to capture them because they are present in the fourth intercostal space, and the depolation wave is much far away from them, okay, and faster them. So most of the books or papers mention that because this wave is very fast and beyond the scope of this V1 lead, therefore V1 and V2 lead is not able to measure this basal depolarization. Therefore there is no deflection, that is zero deflection. Okay, so they will measure a straight line. Okay, but please remember, so I have told you what are the two causes because of which this basal depolation is not measured by the V1 V2. First, this wave is very fast, and second, it is beyond the scope. If by chance a technician put this V1 V2 lead in the second intercostal space or third intercostal space, then this depolarization is not beyond the scope of the V1 V2, and then they will record this depolarization wave. So for example, if V1 V2 is kept in the second or the third intercostal space, then they will record a positive deflection like this. Otherwise they will not. Second, I have told you because the wave is beyond the scope. Second, wave is very fast. If there is a right bundle branch block, so this right side of the ventricle will be now depolarized by the left side. So this wave will be very slow. So in that case also V1, V2 will record a positive deflection like this. Okay. And third case, it can be a normal variant. So what the basic point is, the gist of this is that normally V1, V2 in the fourth intercostal space are not able to measure this depolarization vector of the base because it is beyond their scope. Second, this is very fast. So what are the causes when V1, V2 can record this depolarization wave as a positive deflection? If it is by chance misplaced at V1, V2, or if there is a right bundle branch block, or if there is a normal variant. Now for V5, V6, we know that this depolarization wave is going away. So they will record a negative deflection like this. Now if we combine this, okay, first we will see lead V1 and lead V2. What happened? Because of the septal depolarization in V1, V2, we have seen a positive deflection. So because of the septal depolarization, we have seen a positive deflection like this. So we will draw a positive deflection. Okay. Now, because of the ventricle and septal depolarization, we see a negative deflection in V1, V2. So we have recorded a negative deflection. Now, normally, because of the basal depolarization, I have told you that V1, V2 doesn't record anything. So it will be like this. So net QRS complex will look like this in V1, V2. This is the cause why in V1, V2 looks like this with the S wave and the R wave plus no Q wave. Okay. Now, if by chance V1 V2 is placed in the second intercostal space, or if there is a right bundle branch block, or it is a normal variant, then I have told you that this basal depolation will be recorded by the V1 V2. Then what will be the shape? This part will remain same. This part will remain same because of the septal depolation. Then second, this part will remain same because of the ventricle and septal depolation. But since now V1 V2 will record this basal depolation, so they will have again a positive. They will again have a positive wave. So this will be like this. So this will be called as a secondary R wave, which will be denoted by R dash. So I have told you. So what is the cause of this wave which develops here? It is because of the basal depolation, which is not normally captured by the V1 V2 leads. It is captured if V1 V2 lead is misplaced at second or third intercostal space, or if there is a right bundle branch block, or if it is a normal variant. So when we will be reading in the right bundle branch block pattern, we say that there is a rabbit ear appearance or M pattern or a secondary R wave. So please remember the cause of that R wave is this, what I have explained just now. So in 7% of the patient, it has been seen that because of the misplacements of the lead V1 and V2, we get a right bundle branch block. Okay. Because the technician placed the V1 V2 at second or third intercostal space, and now they V1 V2 start measuring the depolation of the basal area. So we get this secondary R wave. Now if we again, there are a lot of papers on this, and if we again keep the V1 V2 lead in the fourth intercostal space, this R wave will be lost. So how can you differentiate that it is because of the misplacement or it is really a right bundle branch block? It is by the measurement of QRS duration. Please remember, if V1 V2 is misplaced at second or third intercostal space and it start measuring basal depolation, then they can have a secondary R wave, but the QRS duration will be normal, that is less than 120 millisecond or less than 3 small box. So this is what I wanted to explain you about this secondary R wave, why it get in right bundle branch block. Now, if we talk of lead V5 and V6, because of the septal depolarization, what we have seen, V5, V6 get a negative deflection. So this is a negative deflection, and I have already told you that normally V5, V6 can get a Q wave in the earlier lecture. Because of the ventricle depolation, they get a positive deflection. So this is a positive deflection. And then in V5, V6, because of the negative deflection, we get a S wave. So it will be like this. So normal QRS complex in V5, V6 look like this. So it normally has a S wave. Okay. So why this S wave is formed? This S wave is formed because of the basal depolarization. Now in case of right bundle branch block, this S wave, right bundle will be depolarized by the left bundle, so it will be slow. So right basal part depolation will be slow. So this S wave now the width of this S wave will now increase. Okay, so what will be the so that's why increase in the width of the S wave is also one of the criteria for the right bundle branch block. I think I will again explain it, that in right bundle branch block, this basal part is depolarized by the left bundle branch. So the depolarization of the basal part of the right bundle is slow. Therefore, this S wave, which is formed because of the basal depolation of the basal part of the right ventricle, is slow, so its width is increased. Okay, so this is what I wanted to explain to you. Now these are the criteria for right bundle branch block, but first understand this. First criteria, as I have told you, that in cases of right bundle branch block, if there is right bundle branch block, the left bundle will depolarize the right ventricle, so it will take time. So first is QRS duration more than or equal to 120 millisecond or 3 small box. First criteria. Second criteria, in lead V1, I have told you we get a secondary R wave. Why we get a secondary R wave? Because now V1 V2 will get a secondary R wave. Why? Because now the right ventricle will be slowly depolarizing, and V1 V2 will be able to capture the depolarizing wave of the basal part of the right ventricle. So we can get this pattern, we can get this pattern, we can get this pattern, or we can get this pattern. All these patterns, and this will be the secondary R wave because of the basal depolarization, which the generally V1 V2 doesn't measure, but now it can measure because this wave is becomes slow. Why it has become slow? Because now they are not depolarized by the right bundle branch, they are depolarized by the left bundle branch. Third, S wave. What is the cause of S wave in V5 V6? Now we'll see S wave in lead V6 and lead 1. So what is the cause of in lateral lead? It is the basal depolarization. So S wave, this S wave is because of the basal depolarization. Now since the basal depolarization will be slow, why it will be slow? Again the reason is same, because it will be depolarized by the left side. So its width will increase. So we have two criteria to diagnose right bundle. First, if this is your R wave width, this is your S wave width, and this is your R wave width. So width of S wave is more than width of R wave. Okay, if this is the width of S wave, this is the width of R wave, then if width of S wave is more than R wave, this is the first criteria. Or we say that the width of S wave is more than 40 milliseconds. So if these criteria are fulfilled, then we'll call that this patient is having right bundle branch block. This is written like this in books, RSR pattern or white slurred S wave lateral lead. But I am telling you the exact cause. What QRS more than 120 millisecond, any of the pattern V1 V2 or S wave. This is very important. Any of them can be present. The width of S wave more than R wave, or S wave more than 40 milliseconds. Now try to do this question. If you see this question, we are seeing that this is QRS complex. The QRS complex is more than 3 small box. Okay. First criteria. Now in V1 V2 I have told you this is the R wave. Which of the following R is capital? This is bigger, so it will be capital R, this will be smaller. This is second, so this will be called as R dash, and this is a S wave, so this will be called as R dash pattern. So second point is also fulfilled. Now third point was in lead 1 or in lead V6 we will have a deep S wave. So if you see this is your lead 1 S wave and this is your R wave. So we are seeing that width of S wave is more than the width of R wave. This is third criteria also fulfilled. If you also see this S wave width is around 2.5 small box, that is around 100 milliseconds. And for RBBB, I have told you that width of S wave should be more than 40 milliseconds. So this is confident, we can confidently say that this is a case of right bundle branch block. Okay, if I ask you, what are the causes of the right bundle branch block? Okay, so if we see the causes of the right bundle of the causes, the first cause is misplacement of lead. Misplacement of leads. I have told you if V1 V2 is present in second intercostal space or third intercostal space, it will measure the basal depolarization and they will get a secondary R wave. Okay, but here QRS duration will be less than 120 millisecond. First. Second point, misplacement of the leads. Second, it can be a normal variant. And misplacement of lead, it is seen in 7% of the case. 7% of the case. Second, it can be normal variant. Third cause, it can be because of occlusion of left anterior descending artery. Why? You see, this is your heart, this is your bundle of this is the right bundle and this is the left bundle. This right bundle supply comes from the left. We know that we have a left coronary artery. It divides into left circumflex artery and left anterior descending artery. So left anterior descending artery supplies the right bundle branch. So if there is a occlusion of the left anterior descending artery, what will happen? It will lead to anterior septal MI or anterior wall MI, plus also there will be compromise in the blood supply of the right bundle. So that will lead to a right bundle branch block. So this is the first cause. Why? Because the left anterior descending artery, it supplies the right bundle branch. So if there is occlusion of the left anterior descending artery, that will lead to right bundle branch block. Okay, third, mechanical cause. Mechanical causes. Mechanical causes, that means direct destruction of the right bundle branch block. For example, if you are placing central venous line, that can directly mechanically disrupt the right bundle branch. Therefore, it is said if there is a left bundle branch block, then it is a relative contraindication for placement of the central venous line in IJV, because that can also cause right bundle branch block and that can lead to the complete heart block. Second, heart surgeries. Heart surgeries can directly disrupt the right bundle. Angioplasty, also pulmonary embolism, because in pulmonary embolism there will be high pressure on the right ventricle, which can directly destroy the right bundle. Fifth, hypertension. Sixth, age-related disorder. Age-related disorder like degenerative changes. Degenerative changes. Example, amyloidosis. Okay. Then there can be dilated cardiomyopathy. These all are the causes of the right bundle branch block. In left bundle branch block, I have told you A2, H3, D1, that is anterior wall MI, aortic stenosis, hypertension, hyperkalemia, heart failure, and digoxin. And I have told you Zaragoza criteria to diagnose aortic anterior wall MI with other causes. That you should also remember. And these are the causes of the right bundle branch block. Please remember, right bundle branch block does not causes right axis deviation. I am again repeating this point. Right bundle branch block, right bundle branch block does not causes right axis deviation or left axis deviation. If in an ECG of right bundle branch block you are getting right axis deviation or left axis deviation, that means this patient also has a fascicular block. Okay, that I will explain in the next lectures. So if it has a right axis deviation, then that means patient has a posterior fascicular block. And if the patient is having left axis deviation, then he has anterior fascicular block. So please remember, just like left bundle branch block can cause left axis deviation, but the right bundle branch block does not causes right axis deviation. If you want to understand the cause is this. If heart is normally this, the normal vectors is this. Now if there is a right bundle branch block, what will happen? This right ventricle will be not depolarized from the left side like this. So net vector will move here, but still it will be within the normal range of the axis. Therefore, right bundle branch cannot cause the right axis deviation or the left axis deviation. Left axis deviation, though it's very difficult, it does not cause right axis deviation. But left bundle branch block can cause a left axis deviation. So this is a very important point. So whenever in a ECG of right bundle branch block you are seeing right axis deviation or left axis deviation, you should make a point. You should always keep in mind that yes, this patient can have fascicular block. Then you will see if patient has RAD, that patient has a posterior fascicular block. and if patient has a left axis deviation, then it can have an anterior fascicular block. I have already explained in detail the causes of right axis deviation and left axis deviation. Now solve this ECG again. Now we are seeing, if we measure the QRS duration, it is 1, 2, 3. So 3 small box, that is 120 milliseconds. So this is the first point of right bundle branch block that has been proved. Second, which of the following R wave is greater? This is, so we'll write it with a capital R, this as a small r, and this is S wave. This is the second R, so it will have a dash, so it has RS R dash pattern. So V1 also has. Now we'll look at V6. Now V6 here, if you see, now I have told you two ways. One, you can compare the width of S wave with the R wave, and if the width of S wave is more than R wave, then it will be called as RBBB. Second, if the width of S wave is more than the 40 milliseconds. So here if you see the width of S wave and R wave is almost same, but if you see clearly, the S wave has two, see, I will zoom it for you. Now see this. This is the S wave, this is the R wave. Now you can easily see that S wave width is more than the width of R wave. So yes, this criteria is also fulfilled. Second, there are two small box, so that means S wave width is around 80 milliseconds. And I have told you that if S wave is more than 40 milliseconds, it is a criteria for right bundle branch block. So yes, this is a case of a right bundle branch block. Now try to do this ECG. Now if you see this is a broad QRS complex. So QRS is more than 3 small box. First criteria. Second criteria, this is R wave, this is R wave. I have told you this pattern R wave is almost equal. So this will be capital R, this is also capital R, and this will be called as R dash. So R dash pattern. So now in third, we see V6. Now clearly the S wave is more than the R wave. So width of S wave is more than the width of R wave, and S wave is also more than 40 milliseconds or one small box. So this is a 100% case of a right bundle branch block. Please remember, whenever you see a right bundle branch block in a sick patient like ICU patient or fever of unknown origin, a patient who is chronic sick or has a heart disease like rheumatic heart disease, mitral stenosis, aortic stenosis, severe AR, severe MR, okay, or a patient of sepsis. Always, and if this right bundle branch block is a new right bundle branch, always think of pulmonary embolism. Always think of pulmonary embolism. This you should keep in mind, okay. Whenever you see a new right bundle branch block in a sick patient like sepsis patient, ICU patient, patient of fever of unknown origin or chronic anemia or having heart disease like mitral stenosis, aortic stenosis, you should always think of pulmonary embolism. Not in all right bundle branch block you have to think of pulmonary embolism, but in these cases you have to think. So how can you say that this patient has right bundle branch block, also has pulmonary embolism? If the patient, I have told you the history, if the patient has any of those points are present in the history. Second, if that patient is getting sinus tachycardia. Second, if the patient is also getting right axis deviation. Third, if the patient is getting T wave inversion, very important point. T wave inversion in inferior anterior lead, that is 2, 3 and AVF. These are inferior leads and anterior V1 to V4. If this is a very important point, okay. So patient is getting sinus tachycardia, right axis deviation and T wave inversion in inferior anterior lead, that is inferior leads are 2, 3 AVF and anterior leads are V1, V2, V3 and V4, okay. or very characteristic, that is S1, Q3, T3. And what is S1? 1 means in lead 1 patient will get S wave, in lead 3 patient will get a Q wave, and T3 means in lead 3 patient will get T wave inversion. This is, earlier it was known to be most specific and sensitive finding, but now none of the books mention it as a sensitive or a specific. So now it is neither a sensitive neither a specific finding, but yes, if it is present, you should think of pulmonary embolism. Okay. So if all these points are present, then you should think of the pulmonary embolism. So if I say that this patient is a patient who is in ICU with a septic shock, now you are getting and it is a new right bundle branch block, then you will start thinking in terms of, yes, that it can. So what are the point present? Right bundle branch block is present. If we see that if there is an axis deviation present, so I have told you that is I have already taken the class on the axis deviation. So this is lead 1, this is lead AVF. So this is lead 1, it is negative. This is lead AVF, and this is net positive, like this. Yes, so it is getting RA right, and I have told you, if we are getting right axis deviation or the northwest axis deviation or the normal axis deviation, then 2 lead ECG will suffice. Okay, but if we are getting left axis deviation, then to differentiate between pathological and physiological left axis deviation, you have to use 3 lead method. Here there is no 3 lead method, we also use lead 2, but here we don't need to use 3 lead method. That means this patient also has a right axis deviation. Okay, so this patient has a right bundle branch block. Secondly, this patient has a right axis deviation. Okay, now if you see, is the patient has sinus tachycardia? No, sinus tachycardia is absent. If you see T wave, this is your lead 3 AVF, lead V1, V2, V3 and V4. So most of the inferior lateral leads have T wave inversion. So T wave inversion is present in most of the inferior anterior leads. Also, I have told you about S1, Q3 and T3. See, in lead 1 we are getting this S, so this is S1. In lead 3 we are getting Q wave, that is called as Q3, and lead 3 also we get in T3. So we are getting, so this is high chances that this patient has pulmonary embolism. So we can get this. So whenever we have a doubt, so we'll go for the ultrasound of the lower limb to screen out DVT. We'll go for the D dimer, FDP, and if our doubt remains, then we can go for CT angio of pulmonary artery. This is the best diagnosis. MD-CTPA, multi-detector CT for pulmonary artery. Okay, so this is what about right bundle branch block. Okay, now we'll meet in the next lecture.